Welcome, everyone. My name is Márk Hernádfői, and I would like to present my PhD topic and the progress we made in the first 15 months. My vision is to improve survival and quality of life in pediatric oncology, and to achieve that, my mission is to define and improve long-term socioeconomic effects of cancer treatment and research new therapeutical approaches in pediatric oncology. To achieve our goals, we have two main projects going on right now. The first about the social reintegration of childhood cancer survivors, and the second one about the treatment of neuroblastoma. I would like to start with my first topic, which is comparing social and economical outcomes between former childhood cancer patients and the general population. So, as I've said, my main field of interest is pediatric oncology, and when someone asks me about that, usually their response is that it is beautiful, but it must be challenging. And I think that is true because with the latest developments in pediatric oncology, now we are at the stage where we can cure 8 out of 10 pediatric oncology patients, but we still lose a significant amount of children due to this illness. But what happens to those who survive? Can they really heal? Can they forget their cancer? Studies show that they face several challenges during their educations. They are more likely to be unemployed, and they're usually having hardships maintaining a job. They are less likely to be married and have children on their own. Our aim is to investigate the differences in social outcomes between former childhood cancer patients and the general population. We asked the question, do former childhood cancer patients have difficulties in reintegration to society compared to their age, sex, and social status matched control groups who didn't have oncological disease? And our hypothesis is that these survivors have an elevated risk of poor social outcomes. During our systematic search, we were able to narrow 30,000 articles down to around 300. And now I would like to guide you through an imaginary course of life, highlighting some of its main milestones using our data. Our data is presented in forest plots. The unit of measurement is odds ratio in most cases, and we are comparing survivors to the matched control groups and sometimes to their siblings who are unaffected by cancer. And when a study population takes place on the right side of the line of null effect, it means that the investigated outcome is more frequent among the survivors. So we start with the school desk, and the first outcome here is achieving matriculational examination, which is high school degree in some other countries. And as you can see, there's no real difference between the survivors and the populational norms, so they can achieve this level of education. But to see the whole picture, I have to tell you that further analysis showed us that survivors are less likely to achieve the highest levels of education, such as university or postgraduate degrees. On the lower half of the picture, you can see that survivors of childhood cancer have an elevated risk with an odds ratio of around 3 for special education needs. After finishing school, one must find a job, so then we have investigated employment rates among survivors, and we use subgroup analysis based on the survived cancer types and also one additional therapy. And as you can see, in almost every case, survivors were less likely to be employed. I would like to highlight here the case of the central nervous system tumor survivors who have a significantly lower odds or risk of being employed, and also those who received hematopoietic stem cell transplantation during their therapies. Another important outcome regarding employment is income. Studies usually group their subject into low and high income groups. So here we investigated the odds of being in the low income group for childhood cancer survivors. And as you can see, they have a tendency to be in this group. After finding a job, we were curious whether childhood cancer survivors can find a lifelong partner. So we investigated the frequency of marriages. And as you can see, survivors here were less likely to be married in both comparisons, and this difference was significant when we compared them to their siblings. This was also visible in all kinds of tumor subgroups. After marriage come the children, and when we investigated the parenthood among survivors, we found that in every comparison, they were less likely to have children on their own. And now we move on to a little bit different outcome, which is a subjective one, but also a very important one, because it reflects the survivors' outlook on life and the vision about themselves. This is quality of life, which is measured by a variety of questionnaires, and therefore we needed to use standardized mean difference here to be able to pull this data. Here I have highlighted two domains, the bodily pain and the school functioning domains, and as you can see, the reported scores showed no difference compared to the populational norms. However, an interesting finding of our study is when asked about physical health, the self-report of the survivors was comparable and the same as the populational norms. However, when the parents were asked about their children's physical health, they showed significantly worse scores. And now, finally, I would like to draw your attention to some of the health risks that childhood cancer survivors face on the long term. The first is about suicidal ideation and suicides. Here you can see that childhood cancer patients have an elevated risk, an odds ratio of 1.5 to have suicidal ideations or to commit suicide. And also, they have a significant odds ratio of around 1.2 to use antidepressant drugs. So, to summarize this, childhood cancer survivors can achieve the grades of high school education, but they are less likely to achieve university diplomas. They are less likely to find a job, and they usually earn less money than their unaffected peers. They are less likely to be married and have children of their own, but their outlook on life seems kind of positive and comparable to those who didn't have cancer during their childhood. And I also like to emphasize that when we are looking after these patients, it's very important to know the long-term risk factors that they face. I think the main strength of our study lies in its complexity. Of course, it has some limitations. Some outcomes can change with time, and most of the data based on questionnaires. So to conclude, we can and we should establish in pediatric oncology care a disease-specific, nationally and culturally considerate, complex and comprehensive protocol for a lifelong follow-up survivorship program. The importance of this task reaches beyond national competencies. Therefore, this should be performed as a WHO initiative. And the most important thing, if we have a protocol like this, is that we must use it. Now we are at the stage of the article writing we plan to finish at this month. And now I would like to talk briefly about my second project, which is comparing the effectiveness of different therapeutical approaches in the treatment of neuroblastoma, which is the most common extracranial solid tumor in children. As you can see on this graph, the survival greatly depends on the staging and the grading of the tumor. The main problem here is the high-risk group, which has a very low survival rate. There are several therapies now under research, and we would like to identify the most effective treatment modality in the neuroblastoma therapy. So we would like to compare all these applied therapies, and our hypothesis is that there is a therapy among the available ones which is superior in regards of survival and side effect profile. So I hope that my projects support my vision that we are working on the survival, improving survival and improving the quality of life of pediatric oncology patients. And I would like to thank you for your attention with a quote from a Dylan Thomas poem, which says, "Do not go gentle into that good night, rage, rage against the dying of the light." Thank you very much.
Do you have any ideas, or could you say that is there a special type of tumors or malignancies which are more vulnerable for these outcomes?
Unfortunately, in the articles that we found and used for the data analysis, they didn't perform subgroupings based on the tumor type only. And as you can see, these are quite fresh studies, so I think this came to the attention in recent years. and therefore there's limited availability of data in this question. But usually the most affected patients are those who had central nervous system tumors or a long period of therapies.
So there is a factor of severity as well, you might think.
Yes, and also the applied therapies, for example, brain irradiation, usually can have lifelong or really long side effects that accompany the survivor for their whole life, and they have to cope with that.
What was the length of the follow-up, like when they were looking at the work and the marriage? How many years were the patients followed up? What was the range?
Actually, it kind of heterogeneous, because the main rule usually is that these patients have to be at least 3 or 5 years after the end of their treatment, but the age groups differ. So some of the age groups are around in their 20s, some of them can be in their 40s. Well, I think what's important that they are always compared to their age-matched control groups, therefore we can see the real differences.
Can I have one more question?
Yeah, sure.
In the second project, do you have an inkling, do you have a feeling what's going to be the winning therapy, or is it just a hypothesis that there has to be one that is doing better than the others?
Yes, I have a feeling about one therapy that I know of, but that will be under trial in the coming months, I think. So this is actually a targeted therapy called dinutuximab, and there will be a trial, an international cooperation where they try to, they are already using this therapy effectively in relapsed patients, but they would like to use it as a first-line therapy, and I think there's great potential in it.
So that data won't yet be in the meta-analysis, will it?
Unfortunately. Maybe we will update it.
Thank you.
The question relates to the first project. When do you think we should start intervening for patients who are potentially going to be survivors of cancer, and what kind of interventions you can think of? And question number 3 is there any ongoing trial looking at interventions and long-term outcomes?
I think we should start these interventions right at the time of diagnosis, because this comes as a shock to the whole family and all relatives. And childhood is crucially important in regards of psychological and maturing and like personality formation. So I think we need to hold their hands right from the beginning. And the kind of interventions I think need to be comprehensive, like family support, psychological support. Also, we need to try everything in our hands to minimize the side effects and the long-term effects. And also, if we have choices during their therapy, maybe this can be a factor to include in our decision, that try to go with that will most probably has the least side effects or long-term side effects. And I know that there, even in Hungary, there's a kind of a really successful and I think enjoyable intervention that is based on the use of virtual reality, like VR headsets, and I think this is a really great possibility to children.
You showed us some numbers in connection with the quality of life. Could you please go back to this? And yes, some standardized mean differences, yes. And I would like to ask, do they mean real difference in the quality of life?
Well, we had to discuss this because these are different questionnaires. Also, although the domain that they are investigating is the same, that they use a different number and different types of questions. What I have found in the literature is a generally accepted rule of thumb that around 0.2 we can consider the standardized mean difference a mild difference. Around 0.5 it means a moderate difference, and around 0.8 it means a significant or kind of large difference. So we are here around the moderate one.